Okay, let's unpack this. Today we're doing a deep dive into a really exceptional resource. It's Kadasne's Textbook of Anatomy, Clinically Oriented, Volume 1, and it zeroes in on the upper and lower extremities. Our mission here is to give you a really comprehensive, clinically focused summary of the body's structural architecture. This is perfect for medical students, young professionals, really anyone who wants that fast track to clinical competence.
What's fascinating here is that the author is both an anatomist and a surgeon,
Right.
which means the material isn't just theoretical, it's intensely practical. The quote that really sets the stage is, "Surgery is applied anatomy." And every single structure we're going to talk about has, as he puts it, a hidden surgical and clinical thrill.
Yeah.
We're basically connecting the dead house to the living patient.
Absolutely. And that emphasis on functional relevance is so critical now, with things like non-invasive imaging and transplants. So we're going to follow the flow of the book. We'll start with the microscopic stuff, how bones form, how joints work, and then we'll move into the major regions of the limbs and hit those really high-yield clinical correlations.
Right. Let's start with osteology, but not just a list of bones. We need to look at the developmental blueprints because that's where things can go wrong. Bone formation, it all comes from mesenchyme, but through two very different pathways.
Right. So first you have what the text calls the cartilage bones. That's where mesenchyme makes a cartilage model first, and that then hardens into bone. So the humerus, the femur, most of the big bones.
And the other path.
That's the membrane bones, where mesenchyme just skips the cartilage step entirely and goes straight to bone.
And that differentiation is immediately clinically vital. I mean, if the body messes up that cartilage first blueprint, you get defective ossification of those cartilage bones, and the result is achondroplasia.
Short stature or dwarfism.
Exactly. But if the defect is in the membrane bones, like the clavicle or the skull, you get cleidocranial dysostosis.
Oh, I remember that one. That's where the clavicle can be partially or completely missing. So patients can bring their shoulders almost together in front of their chest. It's a perfect example of development directly causing a specific pathology.
It is, and, while we don't need to go through a whole glossary, knowing the language helps. When you see condyle, think of a big, rounded bump for a joint. A trochlee is like a pulley. And a facet is just a smooth, flat area where two bones meet. We'll see these terms pop up again and again.
Okay, so let's take that structure and put it into motion. Let's talk joints. In the extremities, we're mostly dealing with the freely movable synovial joints. What really defines a synovial joint structurally?
Well, it's what the book calls the 7 peculiarities. You have smooth hyaline cartilage on the bone ends, a fibrous capsule holding everything together, and inside that, a synovial membrane making fluid to lubricate the joint cavity. It's a design built for maximum movement.
And when we classify that movement, it's all about the axis of motion, right?
Precisely. You have polyaxial joints like the shoulder, which move in, more than 2 axes, huge range of motion.
Right.
Then biaxial, which move along 2 axes like your wrist. And finally, uniaxial joints. They only move along 1 axis. So either rotation, like a pivot joint.
Like the radial ulnar joints for turning your palm up and down?
Exactly. Or it's a hinge joint, like the elbow, which just does flexion and extension.
Before we move on, what about the other type? The secondary cartilaginous joints, the symphysis joints. The text uses the intervertebral joint as the key example.
Yeah, and the intervertebral disc is so critical there. The center part, the nucleus pulposus, it's mostly water. It's derived from the notochord and acts as this weight-bearing, ball bearing for the whole spine.
So that's why people tend to get shorter as they get older.
That's a huge part of it. That disc desiccates, it loses water, and you lose that cushioning and height.
Okay, let's turn the page to the upper limb. I want to focus on the humerus, since it gets fractured so often. The anatomy here is just unforgiving. You have major nerves and vessels running right up against the bone. Where does Kadasne say the 3 biggest risks are?
You've got 3 distinct hotspots. First, up at the top, the slender surgical neck. A fracture there puts the axillary nerve at risk.
And if that nerve gets damaged, what's the immediate result? What does the patient look like?
They lose the ability to abduct their arm past about 15 degrees. The deltoid muscle wastes away, so that nice rounded shoulder contour, it becomes flat. They call it a square shoulder.
Okay, that's one. What's the second hotspot?
As you move down the shaft, a fracture in the spiral groove is a direct threat to the radial nerve. And the classic motor deficit from that is wrist drop.
Wrist drop, got it. And the third one, down by the elbow.
That's the medial epicondyle, the funny bone. The ulnar nerve runs right behind it, very exposed. An injury there leads to wasting of the small muscles in the hand, causing that classic claw hand deformity.
Speaking of the elbow, the book points out the supracondylar fracture as the most common one in kids, usually from falling on an outstretched hand. Why is this specific fracture such an emergency?
The urgency is all about the brachial artery. The sharp, broken edge of the proximal bone fragment has a really high risk of entrapping or even cutting the artery.
That sounds like a limb-threatening injury?
It absolutely is. In the ER, they have to reduce it immediately and then constantly check the radial pulse to make sure blood flow has been restored. It's a race against time.
That's a powerful clinical point. Now, what about the things that hold these joints together? The book talks a lot about the rotator cuff.
It does. These are the four muscles that basically fuse with the shoulder capsule, acting like dynamic ligaments. They're essential for stability. Every student has to know the mnemonic SDs.
Right. Supraspinatus, infraspinatus, teres minor.
All inserting on the greater tubercle.
And subscapularis, which inserts on the lesser tubercle.
You got it.
Okay, moving down to the forearm. The lower end of the radius is another major fracture zone. The text highlights the Colles fracture. It's so recognizable, it even has a nickname for how it looks.
The dinner fork deformity, yeah. It's a very specific fracture from a fall on an outstretched hand. But the key anatomical sign you look for on an X-ray is the relationship of the styloid processes.
Yeah, explain that.
Normally, the radial styloid, the bump on the thumb side of your wrist, projects lower than the ulnar styloid on the pinky side. In a Colles fracture, they end up the same level. That's a dead giveaway.
That's a great diagnostic pearl. And finally, for the hand, the book gives it so much credit, functionally speaking.
Well, it's superior for a reason, and that reason is the thumb. That 90-degree rotation, the saddle joint with the trapezium, that's what allows for opposition, for gripping. The clinical rule is simple. Loss of the thumb is a 50% loss of the hand's value.
Let's move to the axilla. The book treats it as this critical gateway, a pyramidal space for everything moving from the neck to the arm. What are the key contents running through that space?
The axilla is a major traffic hub. It's walled off by muscles, pectoralis anteriorly, latissimus dorsi posteriorly, and so on. And inside, it's packed. You've got the axillary artery and vein, and of course the cords and branches of the brachial plexus, plus fat and lymph nodes, which help protect everything.
And the brachial plexus itself is probably the most complex thing in there. Trauma to the top or bottom of it causes two very distinct paralyses.
Yes, the two classic extremes. An injury to the upper trunk, C5 and C6, causes Erb's paralysis. You see it after a difficult childbirth or trauma that separates the head and shoulder.
And the arm has a very characteristic look, doesn't it?
It does. It's called the policeman's tip or porter's tip position. The arm hangs adducted, medially rotated, with the elbow extended and forearm pronated.
And what about an injury to the lower trunk?
That's Klumpke's paralysis. It damages the lower trunk, specifically the T1 root. This mainly affects the small muscles of the hand, so it causes a severe claw hand. And because the T1 root is involved, you might also get Horner's syndrome, a drooping eyelid, constricted pupil on that side of the face.
Shifting to surgery in that area, like a mastectomy. There's a vital mnemonic for structures that have to be preserved, the ABC.
Correct. Surgeons must preserve the axillary artery and vein, the nerve of Bell, which is the long thoracic nerve, and the cephalic vein.
And what happens if the nerve of Bell is injured?
You get paralysis of the serratus anterior muscle. This causes a very obvious winged scapula, where the shoulder blade pulls away from the back.
And the tragic part is that because the roots of that nerve are so high up near the spine, the damage is often irreparable.
It often is. Okay, now let's transition to the lower limb, the weight-bearing architecture. Let's start with the pelvis and hip. Before we even get to pathology, we have to talk about the clinical landmarks we use for measurement.
Right, so true limb length is measured from the anterior superior iliac spine, the ASIS, down to the medial malleolus. But if we suspect a hip dislocation, we use Nelaton's line.
Yes. Nelaton's line is drawn from the ischial tuberosity to the ASIS. Normally, the tip of the greater trochanter should be below that line. If you can feel it above the line, that's a huge red flag for dislocation or another serious issue.
Pathologically, the big story at the hip is fractures of the femur neck. The text splits them into two types.
Yes, and the distinction is critical. The most dangerous is the transcervical fracture because it's intracapsular. The fracture line cuts right across the blood supply to the femoral head.
Which puts the patient at high risk of a vascular necrosis.
A very high risk. The femoral head dies, which is a disaster. Extracapsular fractures, thankfully, have a much better blood supply and prognosis.
And what's the telltale sign of a fractured neck of femur? How does the patient's leg present?
It presents abducted and, crucially, laterally rotated. The patient can't hold their foot straight, it just falls outward.
Why does it do that?
It's because the psoas major muscle, a powerful hip flexor, attaches higher up on the femur. It acts as an unchecked lateral rotator on that proximal fragment, pulling the whole limb outward.
Got it. Moving down to the knee, just a quick clinical point on the patella.
Yes, the largest sesamoid bone in the body. And the pathology everyone knows is inflammation of the bursa right in front of it,
Housemaid's knee.
from chronic kneeling. A simple but common problem.
Okay, for our final segment, let's dive into the genius of the foot, the arches. The book calls them the springs of the human body. Functionally, what makes them so special?
They do so much. They provide resilience, elasticity, shock absorption, and they also create a protected tunnel for all the plantar nerves and vessels running underneath. There's a particular beauty to the medial longitudinal arch where we find something called the talar paradox.
A paradox, explain that.
So the talus bone is the keystone. It transmits all of your body weight from the leg to the foot. But it isn't structurally part of the arch itself. It's suspended between the other bones, sitting on top like a rider on a leaf spring. It allows for that dynamic shock-absorbing action.
Wow, so when that spring fails, you get pes planus, or flat foot.
Right, from stretched ligaments or weak muscles. And the opposite, pes cavus, is a high-arched foot from contracture of the small intrinsic muscles.
And we can't talk about the foot without mentioning diabetic foot.
No, we have to. And you have to remember the three primary evils, the SINs, that lead to gangrene. Sugar, for poor blood sugar control, ischemia, for poor blood flow, and neuritis, for nerve damage. That combination is just devastating.
And lastly, ankle trauma. What is a POTS fracture?
It's a very common external rotation injury. It can start as a simple fibula fracture, but if the force continues, it can shear off the medial malleolus and the back part of the tibia. That turns it into a complex trimalleolar fracture, which is a total structural collapse of the ankle joint.
We have covered a huge amount of ground here, from the basic blueprints of bone development to the complex nerve pathways of the axilla, and finally the biomechanics of the foot. The core message from this source is just that anatomy is a living, functional science. Everything we discussed is a clinical decision waiting to happen.
If we connect this to the bigger picture, here's a question for you to think about. It links the functional anatomy of the shoulder with injury. A patient has a mid-shaft humeral fracture. This injures a major nerve that controls shoulder abduction. So, describe the motor deficit, but also explain why this patient might still be able to initiate the action of slightly raising their arm, even though the main muscle for that is gone. Think about the rotator cuff and what each part does.
Use that framework to really cement your learning, because knowing the why behind the anatomy is what turns knowledge into real clinical skill.